Going to the next session of the day. It's basically ocular malignancies and never miss to detect it. So we all see these kind of tumors and lesions in our clinical practice, and there are certain lesions which can mimic an inflammation, a benign lesion, a malignant lesion mimicking a benign lesion. So there are certain things we have to keep in mind, and that's exactly what the objective of this particular session is to raise awareness regarding certain lesions which may look very, very indolent and benign. So we will cover eyelid, we will cover conjunctiva, few of orbit, and also intraocular. So eyelid, we were supposed to have Dr. Seema Das here. She couldn't make it at the last moment. So I'm also going to take the responsibility of doing the eyelid. So we will go with the eyelid first. All right, fine. So it's Dr. Hunavar going first. I think you have another session, yes. So, Dr. Hunavar is the mentor of most of the ocular oncologists who does a lot of ocular oncology work in India, and he has been an excellent teacher. You have already listened to him, and he is going to, take us through intraocular lesions. What is bad and what is good in that aspect. Over to you, sir, and it's an honor to have you in my instruction course.
Thank you so much for considering me. I'll be talking about, can we have the slides? It's a very simple talk on intraocular tumors. I called it 10 pearls because there's a large spectrum of intraocular tumors which sometimes are difficult to differentiate from each other. So let me start with a pearl first and then give you the cases. The first pearl is sectoral shallow anterior chamber or iris hem. Imaging is mandatory. I'm showing you a case of a young adult who presented with shallow anterior chamber, but it was sectorally shallow. You can see shallowness there, normal anterior chamber depth there. That is how it was, intermittently shallow anterior chamber with absolutely quiet AC normal intraocular pressure. So what would you suspect in this patient? Unilateral sectoral shallow anterior chamber or bumps in the iris, peripheral iris. What do you suspect? Something behind the iris, and you can't see what is behind the iris. Of course, you will dilate limbus to limbus and try to peep, slit lamp angulated in the totally opposite way, patient looking in the extreme gaze. You try to see, but many times you're not able to see. But if you're able to see, you will be able to see most likely an iris cyst, because that is the most common. Especially a peripheral iris cyst or a midzonal iris cyst presents with unilateral sectoral shallow anterior chamber. Pupillary iris cyst, of course, is visible, and free floating iris cyst is very, very, very visible. So this is what we found in this patient. You can see a nice well-defined cyst causing humping of the iris and sectoral shallow anterior chamber. So this is very easy to diagnose, but you must do imaging. Otherwise, it's very difficult to say what a patient has. This is a midzonal cyst. This is a peripheral cyst which cannot be seen on full dilatation, whereas a midzonal cyst also presents with a hump, but you can see it on full dilatation. You can see that there are humps in the iris which are pigmented. But what you should be aware of is this situation where if not a cyst, but you find a solid lesion. And a solid lesion behind the iris is either a melanoma or a melanocytoma. So there is a diagnostic dilemma when you see a solid lesion, and it has to be further confirmed. And confirmation is by gonioscopy. Because in this patient, angle is blunted and you see tumor extending to the anterior chamber angle. If you see vascularity in the angle, then most likely it's a melanoma, and of course confirmation is by biopsy. So basically when you see a shallow anterior chamber, sectoral or unilateral in a particular claw cover with humps in the peripheral iris, the only way to diagnose one from the other is imaging, and of course few next steps. Now the second tip is that unilateral glaucoma in a young individual or a pigmented iris lesion, pupil holds the key. You should look at the pupil very carefully. This is an example of a young adult who had unilateral glaucoma where somebody had done a trabeculectomy. You can see an internal ostium there and a very funny circular PI, but you see the pupil already. See, pupil is, it's correctopia and ectropia on UVA, and behind the iris, behind the PI, you should see lens, right, or glow, but here you see something pigmented. So obviously patient has a pigmented lesion behind the iris, and he has neovascularization of the iris as well. So this was a patient with iris melanoma which was missed, and a trabeculectomy had been performed in this patient. Now you can see, as a consequence of trabeculectomy, this is the scleral flap, and under the scleral flap you see the tumor, and even in the bleb you see the tumor. So this tumor, which was intraocular, has been made extraocular by an unintended trabeculectomy. Of course the surgeon did it in good faith, but what was necessary in this patient was imaging that could have picked up the tumor early on. But that pupil was distorted. Now you see this patient who also has a black mass in the angle, high pressure, pupil is nearly nice, round and central. There is no correctopia, there is no ectropia on UVA, there is no NVI, but a pigmented mass is present, pressures are high. So when in this situation, your first differential should be a melanocytoma. So pupil is the key. If the pupil is distorted, if there is correctopia, ectropia on UVA and NVI, most likely it is a malignant tumor. If pupil is nice, round and central, no NVI, you see a black pigmented mass, most likely it's a melanocytoma. This was the mass, that was the anterior chamber angle, and that was a melanocytoma. So melanocytoma presents like this, can also present in the iris, dark pigmented mass with pigment shedding. Melanocytoma is full of pigment, it is pregnant with pigment, it sheds pigment, that settles in the anterior chamber, clogs the trabecular meshwork, and that causes elevation of intraocular pressure. That's a high magnification view. You see no blood vessel at all in it. It's relatively less vascular. Now if you have a diagnostic dilemma about a iris nevus, again look at the pupil. Here the pupil is nice, round and central. It's like a button kept on the iris. It is not distorting the iris stroma. It is silently lying there. Anterior chamber angle is all normal. This is a iris nevus. Whereas these two are melanomas. You can see pupil irregular, zip towards the lesion, and there is vessel here and distortion of the pupil. Both of these are melanomas. There is another way of looking at it, A, B, C, D, E, F. This is okay for kind of description theoretically, but most important is to pay attention to clinical signs. The next tip is that if you see a sentinel vessel, then it's a serious business. Like this patient, he may have cataract, he may have high pressure, he may have neovascular glaucoma, but unless you have done a good imaging, and what is the best imaging in such patients when you see a sentinel vessel? UBM is the best, because you tend to expect the tumor in the ciliary body, not in the choroid. Sentinel vessel is a hallmark of or a harbinger of a tumor in the ciliary body. So you dilate the pupil and you can see a tumor peeping through. This patient did have a ciliary body melanoma. So whenever you see a sentinel vessel, you should be very careful not to jump to do cataract surgery or trabeculectomy, but to do a good 360-degree UBM, concentrating in the area or the sector where the sentinel vessels are, and then make sure that there is no tumor. In this patient, on B scan also you can find a large tumor. Next tip is that if you find uveitis and hypopyon in extremes of age, in a young child, in an elderly individual, it can be sinister. Uveitis is mainly in young adults, generally. But if you find hypopyon in a young child, 5-6-year-old child or 70-year-old grandparent, you should be very careful. This was diagnosed as granulomatous uveitis. It may look like it, but there is attendant blood vessel as well. This patient actually had CA lung. This patient also has multiple nodular excrescences on the iris, but this was a variant of melanoma called tapioca melanoma. You can see on imaging that there are excrescent nodules. This patient presented with hypopyon, yellow hypopyon with multiple iris nodules. He had a colon malignancy, colonic cancer with metastasis to the iris. Now this is a 60-year-old male with left eye hypopyon. He even has a fibrin membrane on the lens. But what is striking in this hypopyon? Or what is not there that you expect in a patient with hypopyon? White eye. So white eye hypopyon is something that is to be considered very significant for masquerade. So if this patient has no posterior synechia, has white eye hypopyon, and that was ALL, lymphoma, sorry. This is a patient again with a white eye hypopyon, and this patient resolved, hypopyon resolved for some time, and then this plastering of the endothelium, large cells on the endothelium reappeared. At that point, he had synechia as well. This patient was being treated as uveitis for a long time until these whitish material appeared in the vitreous, and finally confirmed diagnosis was ALL in this patient. So white eye hypopyon could be lymphoma, leukemia, ALL, AML, or even CML. Now, but in a young child, white eye hypopyon, this is again a white eye hypopyon, could be retinoblastoma. So it can be seeds like this which you see in the anterior chamber, or collection of hypopyon which has a level thick hypopyon in retinoblastoma, or on gonioscopy you can see seeds in the anterior chamber angle. These are all retinoblastoma cells that have come through the zonules and got deposited in the anterior chamber. This is called depository variant of anterior chamber extension. Whereas in this patient, you can see obvious extension into the iris anterior chamber angle, and that is called infiltrative variant. There's a huge difference between depository variant and infiltrative variant because prognosis is totally different in them. If you see a heaped up hypopyon with translucent granules in the hypopyon, in a young child, unilateral lesion, you suspect medulloepithelium of the ciliary body. Medulloepithelium has this balls of cells which are translucent. That's very characteristic. Again, if you find that there is what is called lens coloboma or loss of zonules, because of which the peripheral lens gets distorted and it appears as a coloboma, and retrolental vascular membrane, then that is very typical of medulloepithelium of the ciliary body. Sometimes you find it on the table. This was a pediatric. This patient has an orange lesion, quite one orange lesion you thought, but there is one more subtle orange lesion in the temporal to the macula, and he has similar orange lesions in the other eye. So multifocal orange lesions could be orange metastasis. Orange metastasis can occur classically because of which primary malignancies? Renal cell carcinoma, then plasmacytoma, carcinoid, right? And follicular carcinoma of the thyroid. So these are the causes for orange colored metastasis, and this was a plasmacytoma. Otherwise, orange colored unilateral unifocal lesions generally tend to be choroidal hemangiomas. All these were choroidal hemangiomas. I'm skipping because I don't have much time. All black is not bad, but sometimes black can be reasonably okay. This was a patient with blackish lesion, which is nothing but congenital hematoma, combined hematoma of the RP. This is again a black lesion, crisply defined black lesion with lucent areas. This is congenital hematoma of retinal pigment epithelium, also called chirpy. Chirpy sometimes enlarge in size. Chirpy sometimes become from flat to placoid. That means chirpy is growing into a retinal pigment epithelial adenoma. When chirpy becomes much nodular and develops exudation, that means it is becoming retinal pigment epithelial adenocarcinoma. Earlier, chirpy was considered something that never grows, but actually chirpy can grow, chirpy can become an adenoma or even an adenocarcinoma. This was a very florid growth of chirpy into a retinal pigment epithelial adenocarcinoma. These are rare tumors but can present. Of course, that's an optic nerve head melanocytoma. If you have a pigmented retinal lesion, choroidal lesion, if there are a lot of drusen on top of it, that means that it is a chronic lesion. Any pigmented lesion with drusen or RP changes, or patients who have fibrous metaplasia on top of it, it's a choroidal nevus. Whereas if you find a lot of subretinal fluid, orange pigmentation, then that is a melanoma. That's an obvious melanoma. But sometimes there are issues with diagnosing a small melanoma from a choroidal nevus. So there are rules to how to diagnose it. These are the signs that are elucidated by Shields to find a small ocular melanoma using helpful hints daily. This is a mnemonic. Thickness more than 2 mm, fluid meaning subretinal fluid, symptoms of loss of vision or metamorphopsia, etc. Orange pigment, which is lipofuscin, margin close to the optic nerve and fovea, ultrasound, hollowness on ultrasound, halo because of RPE changes, and absence of drusen. These are the signs which favor the presence of a melanoma. So if you're looking at it and thinking that it was a nevus, over a period of time you can actually see that it has grown. This patient has all the features that have been elucidated in this slide. So if you look at these features and if you find these features, then you should suspect that the patient actually has a choroidal melanoma. So these were the masquerades of intraocular tumors, which I tried to highlight in this short talk. Thank you so much.
Thank you very much, sir, for extensively covering it. So, sir is going to go. If you have any quick question for him, please shoot. Any questions from the audience? Yeah. How many of you deal with intraocular tumors? Have you seen masquerades? Have you ever come across a uveitis patient and then finally it turned out to be a leukemia or lymphoma? No. Okay. Well, it is rare, but just keep it in your mind. Thank you very much, sir. So we go on to the next, that is eyelid, okay? How many of you are thinking of, among the residents, thinking of taking up oculoplasty or ocular oncology? Hands up. Not really? 2? Yeah? 3? Okay. All right, yeah. So, well, it's a very niche specialty, but then, you know, when we talk about oncology, it's more of life that we're talking about. It's whole of the, you know, patient that you're looking into. And since, you know, there are few tumors which are very, very rare, you can go wrong sometimes, and finally the patients lands up with an medical oncologist. But then, you know, we do have a specialty who totally deals with these disease, and I think, you know, you should all be aware of it. Can you open it? No, it's not empty. I've been using it. This one?
This one?
Yeah. You open this one? Yes. Yeah. All right, so we'll quickly go through, and it's an overview of eyelid lumps, certain things that you cannot miss, and few of very rare lesions which, you know, you should have your antenna up in your clinic. So it's very important to know the anatomy of the eyelid, because most of these tumors arises from different structures of the eyelid anatomically, and very generally you should know what anterior lamella is and what posterior lamella of the eyelid is. Anterior lamella, you have skin and subcutaneous tissue, and in your posterior lamella you have the tarsus, which has meibomian glands and other glands. In fact, the sweat glands also arises from the anterior lamella. So anything which arises from the skin and the anterior lamella, there are certain things that you will keep in mind. Something that is arising from the posterior lamella, you will be having certain things to keep in mind. I have no financial disclosures or interests, so I'm going to quickly take you through these lesions over here. It's a very easy peasy diagnosis over here, and you are going to give me the answer. All right, so what do you think this one is? Or at least you can tell me whether it's a good lesion or a bad lesion. Good lesion or a bad lesion? Benign or malignant? Benign. All right, Raksha, you know the diagnosis. Papilloma, yeah. This one, is it benign or malignant? Malignant. And why would you say that? Ulceration. This one, well defined benign, right? Nevus. This one, cyst. This one, sebaceous. Yeah, this is what I meant. You know, this is actually a basal cell carcinoma. So basal cell carcinoma, squamous cell carcinoma arises from the anterior lamella. So anything, a tumor which you feel is a malignant lesion, but it's arising from the skin, then you have certain things to keep in mind, especially BCC and SCC. Whereas something which is arising tumorish or a malignant kind of a lesion, which is arising from the posterior lamella, then we think about sebaceous gland carcinoma. And what about this one? Eyelid. What kind of sebaceous? Blepharitis? What type? Pagetoid? Yes, pagetoid intraepithelial variant of sebaceous gland carcinoma. All right, yeah. So, well, yeah, so these are, we have good lesions here, we have bad lesions here, and I would consider sebaceous gland carcinoma as a lethal lesion, okay? And well, they can present as a pagetoid spread also. So benign eyelid tumors, we all know there are cysts, nevus, hydrocystoma, papilloma, neurofibroma, vascular lesions, and chalazion. Chalazion is something which really is very tricky in most of our practices. So mölignant eyelid tumors, basal cells, squamous cells, sweat gland carcinoma, keratoacanthoma, and these are all arising from the anterior lamella. So this is a 67-year-old gentleman, Indian, lower lid mass for 6 months, rapidly progressive. So anything which is rapidly progressive, again, you have to suspect that it could be a malignant lesion. So what do you think about this lesion? Well, is it a cyst? It's varied in color. There is some amount of vascularity, it is reddish, it is whitish in the center, arising from the anterior lamella. Does it look like a BCC for you? Not really, right? There is no ulceration at all. Yeah, SCC? It's from the anterior lamella, so unlikely to be SGC. SCC, not really. So do you want to fit in somewhere? Or at least do you think it's a benign or a malignant lesion? This is how it looks like. There is large feeder vessel over here. You see this very, very dilated vessel, a large vessel going here. There is vessel over here. So in fact, it does have features. Any tumor with large, thick vessel, always think of a malignancy. It did have features of malignancy. We also have sweat glands in this area. So there are tumors which can arise from the sweat glands also. Something called adenocarcinoma. It can be primary adenocarcinoma arising from the eyelid, or even it can be metastatic, something which is growing in the body, somewhere else in the body, and there is a metastatic tumor. In fact, so these are the differential diagnoses that actually I kept in mind when this patient walked in. Well, it was very surprising for us what we saw. There was so much of glandular tissue over there, and this came out to be a syringoadenocarcinoma papilliform. Okay, SACP. Well, this is a very rare tumor, but these tumors also are seen in clinical practice. So whenever you take a lesion out, never throw it in the dustbin. Every lesion, whether even if it looks like cyst in your practice, send it to a histopathologist. And when you send it to a histopathologist, if you have a very doubt of a malignancy, go for an immunohistochemistry also, because there are certain lesions which is actually diagnosed with immunohistochemistry, and we have progressed much forward in ocular oncology pathology with these investigations. So this is 24 months follow-up. We did a margin resection, which we made sure that it is clear and he's doing fine without any recurrence. So this patient, old lady, who had a cystic lesion in the eyelid 1 year back. So she came with a history of an ophthalmologist doing a needling for a small cyst that she had, okay? And this is after 1 year of presentation. She said after the needling, it started growing, but it has been a slow growth, and it actually looks very, very cystic, right? Very transparent cystic. So, well, this is how the closer look of it. Yes, it is cystic, but something of which I was not very comfortable. You know why I was not comfortable? This is the feeder vessel again, which I was not feeling comfortable about. Okay, now, so it was like whether I just go and excise it or go for a margin excision. Well, I did go ahead with a margin excision, and it was only the skin that I had to excise, because it was not a full thickness excision that we required here. It was absolutely on the skin. And you know what this came out to be? An endocrine mucin producing sweat gland carcinoma. So there are sweat glands in the skin where tumors and malignancies can arise from that also. And this lesion has actually an association with breast cancer also. So she was, in fact, went ahead doing a systemic evaluation mammography, and she came out negative. So in this patient, there was no association, but it is known to have an association. So there are subtle lesions which you come across in your clinic. Sometimes it's a cyst, you needle it, you keep it like that. Sometimes you remove it, you don't send it for histopathology, but it's so very important to send all these specimens for histopathology. This is a very classical case of basal cell carcinoma. Okay, I don't have to speak much about it. It is pigmented. So whenever there is a pigmentation in a lesion arising from the anterior lamella, two things that we keep in mind is basal cell carcinoma, of course. Another one, melanoma. All right, so that is something that you have to keep in mind. So there's a lot of ulceration where the tumor has completely eaten up. We all know that it's called as a rodent ulcer. In basal cell carcinoma, there will be a lot of ulceration, rounded edges, which is very, very classical in this case. All right, there are different forms of basal cell carcinoma: superficial, nodular, They can be morphiform, they can be infiltrative variant, and even a fibroepithelium of Pincus, which is even identified. So these are the various presentations. So although in this patient, when I excise with a 4 millimeter margin, thinking it's a basal cell carcinoma, still, extensive margin dissection. But in fact, it came frozen section margin positive the first time and the second time, because it was definitely a large infiltrative variant. So I excised it, again it came positive, I excised it the second time, and then it came negative. And then that's how we did the reconstruction. So it's very important to go for a frozen section, wide margin excision, frozen section, and prove that the margins are negative for a better outcome in these patients. Now, there is this classification that I'm very fond of in malignant tumors. I call it lethal eyelid tumors. So these are the ones which comes under lethal eyelid tumors. Merkle cell carcinoma in chronological order. Merkle cell carcinoma is the worst as far as lethality is concerned. That is regional lymph node metastasis and systemic metastasis is concerned. Second would be malignant melanoma, and third would be sebaceous gland carcinoma. And why is it so important? Because in our population, the most common eyelid tumor known is sebaceous gland carcinoma. All right, yeah. So there are certain red flags that you have to keep in mind: rapidity of the growth, firmness of the lesion, nodularity, ulceration, lash loss. So anything which is arising from the eyelid, if there is invasion, there will be a lot of lash loss because it invades into the follicles, be it anterior or posterior. So whenever you find a lesion with lash loss, always think of malignancy. Intrinsic vessels, feeder vessels is my favorite characteristic feature to differentiate between a benign and a malignant lesions, and of course regional lymph nodes. Now, well, this is what? Diagnosis. Yellowish in color, posterior lamella, it's just a revision. Sebaceous gland carcinoma, clear-cut sebaceous gland carcinoma, okay? And well, we go for a wide margin excision, and in older patients, reconstruction is not too difficult, so never shy away from, getting a wider margin as far as, considering the cosmesis of the patient. In fact, most of the time, we will be able to actually close it really, really well. So never, never, never compromise on the protocols. Wide margin excision, send it for frozen section. Even if you have to wait where you need a fixed section, you don't have a facility for frozen section, send it to a pathologist. You can wait for 2 or 3 days, expedite the process, and then come for a closure after you make sure that the margins are negative. It's so very important. It's a very interesting case that I recently saw. She came with, she had a history of swelling in the left upper lid, all right? Nothing is seen in the left upper lid, okay? Someone has said it's a chalazion, and that's how she has been referred to me. Nothing is seen in the left upper lid. Anything seen? Nothing is seen, right? And this is what you see on eversion of the eyelid. So it's so very important to avert the eyelid NC. And it's very flat, plaquic lesion, whitish plaque. Infromedial, you can see a little bit of fleshiness. There is lots of intrinsic vessels and feeder vessels. And I was definitely not comfortable about it. Although she didn't have lash loss, but this tumor is very, very slowly infiltrating the posterior lid margin, and there is rounding of the posterior lid margin. In fact, bingo, my first differential diagnosis was sebaceous gland carcinoma. I went ahead doing a frozen section. And in the frozen section, it came margin positive. Actually, the medial margin came positive. So it was a very plaquic, very unusual presentation of a sebaceous gland carcinoma, which was very, very invasive over there. And this is how, the excision that we usually do, and still it came as positive. So this is post-operative 10 days, extensive excision, and then post-operative 6 weeks. So in sebaceous gland carcinoma and the lethal eyelid malignancies, we do go ahead doing PET scan. She underwent PET scan. It was within normal limits. Now, there are very small lesions. This was sebaceous gland carcinoma, but very subtle and small nodular. But as you can see here, the mebumin glands and the ductules are getting affected, and there is a slow invasion over here. So I showed you this case. It's a case of blepharitis, treated with eye drops, treated with Ocubaldi ointment locally, but this has been growing, and this came out to be a sebaceous gland carcinoma intraepithelial variant on map biopsy. So you have to be very, very cautious whenever there is an asymmetric presentation of blepharitis in these patients, and it's quite common in our population. And this is a very diffuse variant of, sebaceous gland carcinoma involving the eyelid and even the bulbar conjunctiva. Map biopsy is what we do in these patients. Pigmented lesions, melanoma. This is a case of melanoma. And well, extensive, I mean, I would go ahead even for 5 millimeters to 6 millimeters wide margin clearance for melanoma. Red in color. Any differential diagnosis? So colors helps a lot in diagnosis. What do you think? Capillary hemangioma? What did you say? आपने कुछ बोला? नहीं बोला. अच्छा. Any DDs? At least give me 2 DDs, please. Huh? Kapoci Sarcoma. He's not HIV positive, not immunocompromised. Yes, but it is definitely a differential diagnosis, vascular lesion. Anything else you want to keep in mind? Merkle cell, yes, yeah. So Merkle cell usually appears like a very, very vascular lesion, and it's extremely vascular and highly metastatic. Okay, so this was a case of a Merkle cell carcinoma. So this is again a vascular lesion, and lots of vascularity, hemorrhage inside the lesion, and this was a primary adenocarcinoma of the eyelid. Skipping that, and this is Kapoci sarcoma. So this was an HIV positive patient, again a vascular lesion. So even reddish lesions, which can appear kind of a benign vascular hemangioma, whatever, you have to keep this in mind. All right, I'm going to skip this. So identify and treating eyelid lesions are very, very important. You have to look into the history, clinical features, ancillary diagnostic tools if you require, and biopsy definitely gives you the diagnosis. So never throw away any tissue, even if looks like benign in your clinical practice. Thank you so much. So I invite Dr. Vikas Menon, who has extensive work in ocular oncology, and he's currently in Chennai with Arvind Eye Hospitals, and he's going to take us through conjunctival tumors.
Thank you, Fairooz. And a lot of this may sound repetitive for people who have attended our surface IC earlier today. But let it be a revision of sorts. I'll just run through the slides and photos
maybe.
Quickly.
Yes, interactive will be really great.
So just a revision basically. So conjunctiva has epithelium, a stroma. So tumors can arise from epithelium, tumors can arise from stroma, and there can be secondary invasion of conjunctiva from the neighboring structures or from distant sites. And broadly, ocular surface malignancies, it's easier to look at them as pigmented or non-pigmented lesions, and that will help you to formulate your diagnosis and localize your differential diagnosis to a fewer possibilities. I'll talk about 5 features that will help you in identifying a surface malignancy. Number 1, a presence of an epibulbar mass, especially if it's a papilliform kind of a large mass. So a papilliform, reddish, large mass, suspect a malignancy. Sometimes you don't see a papilliform mass, but it's still a limbal gelatinous kind of mass which is growing over the limbus. So that again could be a malignancy. So keep that in mind. If you see intra-regional vascularization, that's the second point. So if you have a mass which has got lots of vessels growing inside that lesion, so that's like, a sign which can guide you towards a possible malignancy. Third point will be feeder vessels. So the more the number of points you keep picking up in a lesion that is present on the ocular surface, suppose a lesion has just one of these points, then your suspicion is like a little low, but as you keep on adding these various factors, your suspicion should become higher, and more often you will be able to make a diagnosis just clinically. So the third point is feeder vessels. So you see prominent feeder vessels coming from fornices and entering the tumor. So that's like another red flag. Another patient presented with lots of feeder vessels, and you also see a papilliform large epibulbar mass, and the feeder vessels are adding to it. So that's another patient. So another patient, the fourth point will be keratin. So keratin is deposited on the surface of these OSSN lesions because of the high turnover of the cells, and that's keratin is produced, it gets lodged here. So you have a limbal mass, you have feeder vessels, you have some papilliform areas, and you have keratin. So these are 4 points which you are having. So these will help you to kind of, narrow down your differential diagnosis to OSSN rather than maybe a pterygium or a VKC or things like that, or allergic lesion or something like that. Another patient who presented with a nodular lesion at the limbus. You have feeder vessels, it's a mass, you don't really see papilliform vessels there, but you see a lot of keratin on the surface. That again was a patient on biopsy proven to be OSSN. So you will have varied amount of keratin on these lesions depending upon the rapidity with which the cells are multiplying and or they are proliferating. So another patient with keratin, feeder vessels and the works. Another patient, so exuberant keratinization here. So some of these patients may have very obvious keratinization, some patients may have more subtle keratinization. So you have to keep looking for these signs to be able to make a good clinical diagnosis without the biopsy. But again, you see lots of other signs that we talked about: feeder vessels, mass, area which has got some lesion with an intrinsic vascularity, and keratin. So all these things just add up. And number 5th is the rose Bengal stain. So if you stain these lesions with rose Bengal and see them under the green filter, then more often these lesions will pick up the stain and will also help you to characterize and define the exact extent of the lesions. And this is what you should do pre-operatively in your OPDs on slit lamp, because sometimes you may not see subclinical cells which are still there, but the positivity may sometimes at times extend beyond the lesion itself, and that gives you a clue that when you are planning your surgery you have to take that area out as well. So OSSN that we just talked about, that's basically ocular surface squamous neoplasia. It's squamous cell carcinoma or carcinoma in situ or dysplasia. This is just this term that we use. The exact diagnosis can be made histopathologically, whether it's just a dysplasia or you're seeing is a CIN or a carcinoma in situ, or it's a invasive squamous cell carcinoma. So these were some epithelial lesions. Dr. Fairooz just highlighted the need for eversion of the eyelids in these patients. This patient actually presented with nothing but a persistent discharge in one eye for a prolonged period of time, for which she was on a lot of antibiotics, steroids, lubricants, everything tried for a long time. But simple eversion of the eyelid revealed that she had a papilliform lesion on the upper tarsal conjunctiva that was nothing else but squamous cell carcinoma. And again, a patient with unilateral kind of blepharoconjunctivitis, elderly patient, and at extremes of ages you need to be more careful about these lesions. So you have this thickening of the lid margin, and you have this rose Bengal staining, and you have a gelatinous kind of mass which is just covering the entire surface. You evert the lid and it's even extending up to the lid margin and involving almost the whole of upper tarsal conjunctiva. So this was again a very diffuse OSSN. You need to differentiate these lesions from pagetoid sebaceous gland carcinoma, as she's mentioned. So just keep an eye open. Sometimes, these patients will undergo a surgery. Somebody will try to operate, and my stress is always that, the first surgery is the best chance that you have to treat these patients. If your first surgery is faulty, then, you're just messing up with the patient actually. And then the subsequent surgeries or whatever treatment we do is likely to be much less effective than the first time if it is primary treatment is good. So patient underwent some surgery. So especially when you have a patient where you have a high suspicion of OSSN and underwent some surgery or something, always do some sort of imaging to see the depth of invasion. And anterior segment OCT is one very good non-invasive modality that we now have, which showed us the depth of invasion into the sclera of this tumor, which is already going into the sclera. So this patient will need management in a different form. So not just excision, but you have to counsel the patient that after excision, you will also have to go for plaque brachytherapy. Another patient who presented with something like a hypopion uveitis, but here you see there is a scar on the conjunctiva. So this patient had actually undergone some sort of surgery. She didn't know what exactly the surgery is, and patient coming from a periphery. But some surgery has been done. You see the scar and you see this kind of presentation, and there are lots of clumps of cells actually in the anterior chamber. So something has gone inside the eye, and you want to know what is happening there. So a UBM is helpful in such cases. You see the ciliary body is thickened. So basically this was a squamous cell carcinoma which had gone inside, invaded the ciliary body, and the cells were seen in the anterior chamber. Now such patients would require a more radical treatment. The eye had to be removed, of course. In most other cases where the tumor is nice, superficial kind of a thing, then topical therapy helps. We've spoken about this in detail in the earlier IC. So the most preferred treatment, topical therapy that we use is interferon, topical interferon. This was a patient, gelatinous mass, disappeared after 2 months of interferon. Another patient with a slightly larger lesion, which completely regressed in 3 months after topical interferon. So there are specific indications for topical chemotherapy, not that every patient is, you give that interferon or mitomycin blindly. So basically, one is that if you are planning an excision but the lesion is too big, so you want to reduce the size of the tumor, then you give topical chemotherapy and then take up the patient for surgery later. If it's a very diffuse lesion where you think surgical excision will not be possible, that's one indication. If you've done a surgery and the excision edge reveals a CIN type of lesion positive in the edge, not invasive carcinoma in the edge. If it's an invasive carcinoma on the edges, then you have to go back and do surgery. But if it's like a intraepithelial neoplasia with in a positive edge, you can start a topical chemotherapy. If there are multiple recurrences with treatment failures, pure corneal lesions or elderly or debilitated patients not fit for surgery, there you can try topical therapy. Surgery is the gold standard for most invasive tumors, and we do get good results with the standard technique of a no-touch technique, taking a wide margin around the lesion, clearing up the entire thing, and then adding adjuvant cryotherapy at the time of surgery. That's the best time you want to add adjuvant therapy. So cryotherapy to the remaining edges of the lesion, of whatever conjunctiva is there left behind. So you add cryotherapy, double freeze-thaw cycles. We saw a video earlier in the day, and then covering the defect with the AMG. The results are usually very good. Moving on to some of the stromal tumors. Stromal tumors basically it can vary a spectrum. It's a spectrum from benign to malignant tumors. So this child presented with a pinkish mass with some intrinsic vessels. So when an abnormal vascularization is seen, so even if it's a younger patient, then we have to see what is it. And this patient was taken up for biopsy. It turned out to be a benign reactive lymphoid hyperplasia. Whereas this elderly patient came with a similar looking mass with a lot of vessels in the lesion, a large pinkish mass. You couldn't see the posterior extent, so in such cases imaging is required, biopsy is required. This is a classical case of a lymphoma, malt lymphoma, and depending upon whether there is systemic involvement or not, you plan chemo or radio. Pigmented lesions we just discussed short while back. I'll just run through. Basically, there are a few types of pigmented lesions that we see in EY, where you need to look at these cysts, which tell you that it's a nevus and not really a malignancy. And this is something which you need to be more careful about. This is primarily acquired melanosis, which is like irregular diffuse pigmentation of the conjunctiva, and it can be with or without atypia. If it's with atypia, there are high chances of having a melanoma like this. So this is basically a melanoma which developed from a pre-existing PAM. Most of the melanomas develop from pre-existing PAMs with atypia. So these are just the cases which we saw earlier in the day also, and some of them are fresh. So thank you very much. Thank you, Fairooz.
Thank you very much, Dr. Vikas, for an excellent overview. Do we have any questions for Dr. Vikas? I'm sure conjunctival lesions is something that even a general ophthalmologist would be managing in their practice. Sir, do you have any questions? All right. So we go on to the next one. I'm going to take you through the orbital lesions. So we all know that orbit is considered to be a Pandora's box, and you can have actually surprises in the orbit. So it's a very straightforward presentation. We're not going to deal with normal orbital tumors, but those which actually mimics like inflammation and other disorders, and then it can be lethal, and you should not be missing in your clinical practice. This is an analysis of a large analysis of 2,480 space-occupying lesions of the orbit. And what they have reported is that, 68% were benign, but 32% of the lesions in the orbit were malignant. And most commonly what they found was, even among the the 8 most frequent orbital tumor, non-Hodgkin's lymphoma. And lymphomas can actually mimic in different forms. Well, sphenoid wing meningioma, optic nerve meningioma, these are benign lesions. So among the 8 most frequent orbital tumors, lymphoma is actually topping the list. And you have to keep that in mind. So I'll just take you through few pediatric cases and then come to adult. So this child is from the remote village in the central India who was referred for diagnosis and management. In fact, 3-month-old baby girl, and it was diagnosed to be an orbital cellulitis in this child. And for 10 days the child has been having proptosis. Well, yes, there is severe proptosis, but it doesn't really fit into orbital cellulitis. The child didn't have any history of fever, and the parent says there has been a very rapid progression in 3 days. Okay, so this was how the child looked like when the child was born, and subtle proptosis happening. So this doesn't happen in an orbital cellulitis, right? Yeah. So you always need to ask the parents or the patient for previous pictures whenever they come with proptosis, so that you know exactly how the disease has actually progressed. So it was like a sudden proptosis, yes, orbital cellulitis infective, that's what we would keep in mind. But well, the child has started having proptosis as a baby, and this was how the child came into. So we went ahead doing an MRI imaging, and it seemed to be a very high grade malignancy. And why do I say it's a high grade malignancy? Of course, the rapidity, the size of the lesion in this baby, and you can see this central, it's an heterogeneous lesion. Heterogeneous means there are different colors in the same lesion. There is different component in the same lesion. And this is kind of very cystic kind of a thing. You see that? That means indicates that there is necrosis. And when does necrosis happen in the tumor? When there is a very advanced high-grade tumor, where the tumor has grown out of proportion to the vascularity where the tumor can have, and then the central area goes for necrosis. So whenever you see these cases, you're really worried. Okay, so what we went ahead doing was to go ahead and debulk. It's very difficult to do the entire excision in this case, because you can see the lateral rectus is absolutely not seen. It is something arising from the lateral rectus. And in the presentation, the child had an esotropia also. So well, we went ahead doing maximum debulking. One was basically for diagnosis and also to reduce the tumor load. We went in for a very rapid diagnosis. In fact, it was like a frozen section, because I was very curious, and the tumor was growing so rapid. So we went in for a rapid diagnosis, and it came out to be an orbital rhabdomyosarcoma in a 3-month-old. It's very young age for a 3-month-old to have an orbital rhabdomyosarcoma, and this came out to be a very high-grade lesion. So well, we do have international classification. All the protocols are in, and in fact, the child went ahead receiving the treatment, and still the child is on treatment. So the child has not completed the treatment. Yes, yeah. So this is yet another case, a 10-year-old girl, proptosis, rapid progression, diplopia, mild pain. Again diagnosed as a case of orbital cellulitis. Does it look like orbital cellulitis? Not really, right? Yeah. So well, was seen in a government hospital, and then they were kind of doubtful that it doesn't look like an orbital cellulitis, and this is how it looks like. There is so much of subconjunctival hemorrhage. What does that mean? That there is lot of vascularity. Whatever is growing has got lots of vascularity, and it's actually causing subconjunctival hemorrhage. Imaging was done, and this is what we see in the image. Okay, so you have this lesion in the orbit. What all do you see here? It's not only the orbit which is involved. You see this temporal fossa, it's involved. You see the cranial fossa, it's involved. When you compare the bone of the normal side, the right side and the left side, you can see there is some amount of hypersclerotic bone which is there, and also there is bony erosion. So whenever there is hypersclerosis and bony erosion, mostly it actually gives way to the diagnosis of a malignancy. So this is what we have always been taught, like even in our fellowship. Whenever you find a triradiate lesions, this is called a triradiate lesion. Tri involving 3 spaces, all right? Neuroblastoma, PNET, sphenoid wing meningioma, plasmacytoma, leukemia, and lymphoma. This is mostly in the adults. When it is a child, you should always think of a neuroblastoma or a PNET. And well, we went ahead doing an incision biopsy, and it came out to be an Ewing sarcoma. So this is actually the panel of immunohistochemistry that we do, we go ahead. So it's just not like talking about sarcoma. We actually need to know specification of the tumor. In fact, we even do genetic markers now. So that is how things have progressed, and it also helps us to know what's the prognosis of the lesion, whether there has to be a deviation in the chemotherapeutic agents which has to be done. So this is the extensive workup, pathological workup that goes behind all these things. And in fact, bone marrow biopsy and PET scan was normal, and the child was lucky. So she went ahead, doing she completed a treatment, and for the past 3 years, she has been disease-free. Now this child, you are going to give me the diagnosis here. Okay, I'm not going to talk about this. I'll just give you the history. 11-year-old boy, history of fall, eyelid swelling, eyeball bulging. This case was actually referred as a case of retrobulbar hemorrhage to my oculoplasty practice, not to my ocular oncology practice. Okay, like whether there is trauma, whether blood has to be drained, there is retrobulbar hemorrhage, etc., etc. There is ecchymosis, and you can see, well, there is absolute severe proptosis in the left eye. Do you think the right eye is normal? It's not, right? There is some kind of fullness over there. Does the child look normal? What do you feel? I mean, yeah, even the cheek, right? So the cheek is full. The child is very emaciated. Lots of pallor. Can you see? Like, he's very pale. The child is very, very pale. So a child presenting like this, what would you want to do? Well, imaging, of course, I do have imaging for you. All right. So there is a large lesion in the left eye, and there is some amount of diffuse lesion sitting in the right eye also. So what would you want to do? Tell me the diagnosis. Peripheral blood smear, yes. Ultrasound abdomen, yes. So only thing that I did was to go ahead and do a peripheral blood smear. And why did Dr. Raksha say peripheral blood smear? Any resident? Leukemia, right? Yeah. So any ecchymotic lesion causing proptosis, you should always think of leukemia infiltration, or what we call it as granulocytic sarcoma. And this is what was seen in the peripheral blood smear. And that's all that we need to do. I didn't even go into the orbit to take a biopsy. Peripheral blood smear, diagnosis done. Patient was referred to a pediatric hemato-oncologist, but the child didn't make it. The child died due to the disease. So this is a very interesting case, where the child complains of on and off inflammation. Okay, so preceptal cellulitis, it comes, it goes. And this is in fact the child who came to the clinic. This was how she looked like. Then I was like, no, there is absolutely no. Then the referral doctor said, no, there was peripheral, there was some amount of preceptal cellulitis when she presented to me. I'm like, absolutely, it's so, there is nothing happening. And then I had to go ask the parents in their phone, how the child was. And this is how she used to have on and off swelling, and she was under observation. So whenever there is an on and off swelling in the orbit, there are two things that we would keep in mind. One is infections like tuberculosis can cause these kind of picture, and the major thing is histiocytosis, okay, like Langerhans cell histiocytosis, eosinophilic granuloma. So this is what her imaging looked like. There's a lesion in the orbit, and in fact there is complete erosion of the roof. Luckily, the dura is intact. It's not going inside the brain. So this is a large lesion. We went ahead. Curettage was done because there was a suspicion of a histiocytic disease, and it was given immediately, and then it was proven to be histiocytic disease. Maximum curettage. I gave an injection in triamcinolone acetonide. It's not a malignancy, okay? It's just a benign lesion, and immunohistochemistry proven to be eosinophilic granuloma. So it looked like a malignant lesion, right? There is bony erosion. So whenever there is a bony erosion, you think of a malignancy. But there are benign lesions also which can present as a malignant lesion. In this situation, actually, eosinophilic granuloma and histiocytic lesions has association with chronic myeloid leukemia also. And they can have these lytic lesion in other part of the body as well. So a complete whole body scan was done, but everything was clear and she was doing fine. So this is how she actually looked like after 3 months. In fact, the bone formation also happened. She was free of the disease. The bone is back. Everything is perfect with steroids and removal of the lesion actually. This is a very interesting case. So this was a 40-year-old lady. She is, chronic history of sinusitis. She has always been telling, sinusitis, and it's been like a very, very chronic history. And the sad part is there is a very, pronounced family history of cancer. Father with esophageal, mother with ovarian cancer, grandmother with ovarian cancer, and maternal aunt with ovarian cancer. So, when a patient walks in like this with a very strong family history, you are kind of thinking of something which is lurking around. And she's on steroids. When she stops the steroids, again, the lesion and the puffiness comes out. Although, it's not very, very clearly seen here, she definitely had a palpable mass in this area. And there is a lot of fullness over here, okay? So I was not comfortable, any cellulitis kind of a picture, any periocular puffiness, which is on steroids, it goes away and it comes back, it definitely requires to be biopsied because there can be something which is lurking around. And then, she also had a mucosal polyp in the sphenoid sinus. So the working diagnosis, I really didn't think of a malignancies, to be very honest, inflammation, infection, because she also had a kind of a septal necrosis. The nasal septum was necrosed. So venous granulomatosis was in the high list, but it came out pathologically initially as Rosai-Dorfman disease. Well, it was not really fitting into it, but then we went ahead doing an immunohistochemistry because there was so much of doubt, lots of plasma cells, and it came out to be a very rare lymphoma, a natural killer T-cell lymphoma. And she also has systemic involvement. In fact, she had a nasal disease which was actually extending, taking long process and extending into the sac area. Her sac was fine and it was a perisac lesion. So very sad disease, and the patient didn't make it as well. So this was a case actually which happened during the second phase of COVID, where he's a diabetic patient, lot of orbital cellulitis like picture, was referred as a case of possible fungal disease, okay, mucormycosis. Well, it was not looking like mucormycosis because the sinus is absolutely clear. We all know that mucormycosis arises from the sinus, and then it goes to the orbit. Sinus absolutely clear, even the maxillary sinus, ethmoid sinus, sphenoid, everything was clear, and it was actually over here. And this was also a case of a natural killer T-cell lymphoma, and both of the patients didn't make it. It's a very, very aggressive lymphoma. Although they presented as an orbital cellulitis and an infection, it turned out to be a malignancy. Now, this patient was referred to me for dealing with the ptosis that she has in the right eye. She does have a ptosis, right? She was sent for a cosmetic, correction. But what is more pronounced here is that kind of a fullness. We usually don't see fullness in ptosis, especially in an acquired aponeurotic ptosis. You have a high lid crease. You don't get fullness there, right? Yeah. So it was not like fitting into, and I didn't want to go and do a ptosis surgery in the patient. The first thing that I did was to do a imaging. And this was what I found, a lesion which is in the supromedial orbit, closer to the bone is intact. Went ahead, did a biopsy, and in fact this lesion was this is actually a superior oblique tendon, and it was wrapping around the superior oblique tendon, all right? And this is how it was excised, and this came out to be again a lymphoma, very rare, a follicular helper phenotype. Unfortunately, in this patient, the patient had the PET scan was done, and she had systemic involvement, abdomen, para-aortic nodes, cervical nodes, and bone marrow biopsy was positive. A very subtle ptosis, very subtle periocular puffiness, but see the extensive disease that she has with a rare lymphoma. In fact, yeah, she was stage 4. She went ahead receiving all chemotherapy and she made it. All right, 50-year-old lady with eyelid drooping again, complete drooping. She was treated as a case of myositis, and this is how thickened her superior rectus LPS complex is. All right, yeah. So whenever a patient is kind of subsiding with steroids, but still not, she was treated as myositis, a little bit of resolution, and again the swelling comes back. In fact, this was a muscle non-Hodgkin's lymphoma. Okay, so they can also present like myositis. So role of biopsy in orbit has a very, very pronounced role. Whenever you are in doubt, go inside, take an incision biopsy, and prove that is inflammation. Until otherwise, always think of these very bad lesions which is lurking around. This patient, last case, 52-year-old gentleman, bulgy eyes, recently noticed. He was diagnosed to have a sphenoid wing meningioma clinically, And, this patient came for a second opinion. And, well, I would also think of a sphenoid wing meningioma, right? There is, again, bony erosion over there, extending to the temporal fossa, lateral area. And this is typically how it looks like. But, well, in order to treat it, we always require a pathological diagnosis. So, thinking of sphenoid meningioma again, I went ahead doing a pathological diagnosis, but that was again a surprise. It came out to be a lacrimal gland adenoid cystic carcinoma, eroding the bone from the lacrimal gland area and going into the temporal fossa. So I would just want to emphasize that. Yes. Yeah. Correct. So I actually didn't think of an adenoid cystic carcinoma at all. So the referral doctor also was a specialist. They had diagnosed sphenoid wing meningioma, and I also thought it's sphenoid wing meningioma. Since the patient came to me, he was willing to do a biopsy with me, and I did a biopsy, and it came out to be an adenoid cystic carcinoma. And this patient had, he is still alive, but he developed systemic metastasis despite the treatment, because whenever there is an extension into the temporal fossa and the bony involvement, always they have a very poor prognosis. But he's still alive, with a small lung nodule which is existing. Yeah, so yes, that comes to the end of this instruction course. It's just to educate you and raise the awareness of these lesions, which sometimes looks like very benign, even in eyelid, conjunctiva, and orbit, but well, it most of the time masquerades. So keep all these things in your mind and your practice. And well, yeah, that's it. Thank you very much. We can take any questions quick if you have. No questions? That means you understood everything or you did not understand anything. Acha hai, sir? Yeah. Any question? Aware ho gaya, theek hai. So now Aishwarya Rai is waiting. I'm leaving you all guys much earlier than so we have the inauguration. Yeah, so don't miss it. All right, yeah. No questions? Can we wrap it up? Yeah, wrap it up? All right, perfect. See you around and have a good AIOS 2022. Yeah.